Now we have Professor Ignacy Carrió with the lecture, Future of Nuclear Medicine, the European Perspective. Professor Carrió.
Thank you very much, Dr. Estrada. Let me start by congratulating Andrew Scott and all the people involved in the organization of this important and very successful Congress. Andrew, my congratulations. Now, in the next 25 minutes, I will discuss for you my views on what lies ahead for us in nuclear medicine and molecular imaging. These are my disclosures. I have received funds and honoraria from the companies listed here. And for a talk about the future, I have another relevant disclosure. And this is that I do not have a crystal ball. A crystal ball where I could foresee what lies ahead for us, what can we expect in the near future. But on the other hand, I mean, having a crystal ball might not suffice, because what we might see in there could be even worrying. So let's stick to the facts and see what lies ahead. And let me start by this statement on technology. I believe that in the near future, all scanners will be digital. We will move from the photomultipliers to solid-state digital detectors. We have already done this move and have installed our first digital scanner from this particular vendor, but other vendors will do the same and will move along the same direction. Certainly, the images are improved. This is an example, one of our patients. You may easily see that it is a choline PET scan in a patient with a prostate cancer. On the left side, the analog scan, the digital scan here, the digital images here, the analog images down there. The contrast is higher, the systems are faster. Notice, for example, this spinal lesion, which is clearly seen on the digital PET images and could have been missed in the analog images. Will these improved images change our paradigms? That we don't know yet, but there are certainly opportunities here. We know from the Nelson trial that a significant proportion of small pulmonary nodules, here shown as from the volume doubling time or the volume of the largest nodule, a significant proportion of these small nodules turn to be malignant. And the current paradigm is that often we have to report that we cannot characterize metabolically a nodule, most likely because of the small size. And that paradigm may change with the introduction of the digital scanners. Same may happen in lymphoma. This is taken from the current guidelines. You will recall that a positive finding is defined as increased FDG uptake. So with these new digital scanners, we may impact also our practice by detecting smaller lesions in lymphoma. Or in the brain, where we have potential for much better quantification. This is how we present now our images for the brain. You will see the high quality of the FDG scans. We typically use a 1 millimeter PSF reconstruction, and see the quality of the images for amyloid or for tau with the tracers to which we have access. Another comment on technology. I was 2 months ago at the World Mobile Congress in Barcelona, and I was there impressed by the 5G hyperconnectivity that is coming, that will bring true hyperconnectivity without lag time. I was impressed by the more than 100,000 attendees, but especially I was impressed by the facial recognition at entrance that rendered the use of badges useless. Well, if software can distinguish a face among 100,000, this type of softwares can easily read a scan. PET scan, PET CT scan, MR if you wish. So certainly this technology is there and will have an impact on our practice. But we can take advantage of these technologies too, and I offer an example. This is coming soon in the EGNMMI. It comes from France. It is a study that shows that by incorporating artificial intelligence in our reading, we can evaluate what they call tumor fragmentation, estimated by volume surface ratio of tumors. And they demonstrate that this is an independent prognostic factor in diffuse large B-cell lymphoma. Notice that this patient here and this other patient here, they have the same or very similar metabolic tumor volume, but the outcome is different in terms of this, in relation to this volume surface ratio measured on the scans. So with this that is coming to impact on our practice, we learned at the first plenary that we are being disrupted every day. What shall we do? I believe that what we need to do is to stick to medicine and to keep thinking as doctors, not as image readers. And therefore, we must first identify the clinical problems and then the solutions, not the other way around. An example of a clinical problem. This is the current situation according to the phase 3 controlled trials published on treatment of metastatic castration-resistant prostate cancer. You see here, these trials just show a very modest improvement in survival, just a few months difference in overall survival. Therefore, there is a problem there, an unmet clinical problem. So there we can offer a targeted solution. Well, in oncology, staying targeted is important. Chemotherapy claims to be targeted, but here we can compete very well with advantage. And let me just show you a few data. The androgen receptor in most abundant tissues is in the order of 5 to 70 picomoles per gram. And this is in the testes, not in the tumor. The cytochrome CIP17A1, which is the target for abiraterone, is in the concentrations between 10 and 1,000 picograms per milliliter. On the other hand, PSMA is present in much higher abundance, in much higher concentrations, in the order of 300 to 4,000 nanograms per milligram of protein. So these differences in the concentration of the target then result in much different % of the injected dose per gram in the tumor. So in the case of abiraterone, for example, the testes reach only 1% of the injected dose per gram, while 12% goes to the bone. In the case of docetaxel, which targets tubulin in the cells, a universal target, only 0.01% of the injected dose per gram goes to the tumor, while 40% goes to the liver. On the contrary, PSMA ligands, when we inject them, 1 to 24% of the injected dose per gram goes to the tumor. Therefore, if targeting is important, here we compete with advantage, certainly. So therefore, then we can propose a diagnostic model, same as we did in prostate cancer. We offer the gallium labeled compound, and then we treat the lesions with the lutetium labeled compound, and we can demonstrate the response in images that are very easy to understand for the oncologist, highly intuitive, highly demonstrative. And in this type of sequential images, we show the effect, the benefit of our targeted treatments. Is the data available good? I will just offer a systematic review that is coming soon in EG and MMI. In this systematic review, the authors bring together the results of 12 studies with PSMA, more than 600 patients, and compare with third-line treatments in 16 studies over 1,000 patients. So notice that the best PSA decline, more than 50% of PSA decline, is more often reached with PSMA as compared to third-line treatment. The frequency of objective remission is also achieved more often, significantly more often, with PSMA rather than with third-line treatments. While still survival is not significantly different. However, we must be aware of the pros and cons of our approaches. Likely, targeted radiotherapy, if you like the term, will become clinical practice. And this is because our theranostic models are powerful and are clinically meaningful. They represent true targeted radiotherapy. The data we have is good, but we need randomized phase 3 studies. Without such randomized phase 3 studies, oncology is not going to take us seriously. We must produce soon this data. And we must be aware of the hurdles. There are regulatory issues across the world, and we need to offer business models. I mean, otherwise, industry interest and support, which is necessary to conduct randomized phase 3 studies, may lack. And then we should not forget that our time window will not stay forever. In prostate cancer, for example, molecular subclassification of tumors is coming. And that may change relatively soon the way we address prostate cancer in medicine. And that leads me to what was already introduced by Sanjiv Gambhir. Real-time liquid biopsies have become a reality in cancer treatment, and this is likely to have a huge influence on how we use imaging. The detection in peripheral blood of cells or DNAs or RNAs or fragments allow the demonstration of the presence of the disease somewhere in the body. Let me recall that this not has to do with oncology only. So same way as tumors release these substances, these fragments in the blood, same does the healthy tissue or inflamed tissue or apoptotic cells. So the concept of liquid biopsies can easily be extended to other areas in medicine beyond oncology. Probably you are aware of this article published in Science this year by the Hopkins Group. They offer a multi-analyte blood test for a screening of tumors. And you will notice that the system works quite well for different types of tumors, ovarian, liver, stomach. Here, the accuracy for prediction in colorectal cancer, ovarian cancer, pancreas, and others. So for screening even, this concept works. Even in an area that we tend to think that it belongs to us, neuroendocrine tumors. Notice here this recent publication on the use of a blood-based 51 net-specific transcript set for diagnosis and monitoring of neuroendocrine tumors. Look in this part of the slide. The red dots are patients with progressive disease. They are very well distinguished from patients with a stable disease and obviously from control. So it works in neuroendocrine tumors. And same as we do with PET-CT, this approach, this concept can be employed to design clinical trials. This is just an example in breast cancer. So notice how the different arms in these trials behave different in terms of outcome, depending on the presence or absence of the cells or the DNAs in peripheral blood. And new treatments. We learned yesterday from Rodney Hicks that PET-CT can work well here if we understand the findings, if we learn to understand the findings. But you can do the same by assessing the molecular signatures of circulating melanoma cells. Notice in this recent study how for the assessment of progression-free survival or for overall survival, it is easy to use this approach to distinguish between patients who are responding from the patients who are not responding. So in this scenario, how do we position ourselves? In general, I believe that for initial diagnosis, imaging will keep playing a role. Then the tumors will be characterized either by immunohistochemistry or genomic assessment or both. Then when staging will be important, PET-CT will stay as the primary technique. But then for the assessment of response, I believe that the liquid biopsies will be the central test. And there, we can offer our multiparametric imaging, combining PET-CT, MR, and other signals, and try to demonstrate added value to liquid biopsies. I believe that this is the way to go. And I will offer a few examples. This is coming soon in EG and MMI. It comes from France. This group is suggesting to combine genomics and baseline PET-CT for prediction of outcome in large B-cell lymphoma. Notice in this part of the slide, just by employing the measurements of metabolic tumor volume on FDG PET-CT and using a given cutoff point, we can distinguish two types of outcomes, of course. If we use the genomics only, we can do the same. Depending on the phenotype, the so-called CGB phenotype has a better outcome as compared to the ABC phenotype. But if we combine the genomics and the FDG PET signal, then we are left with three groups. Patients with small tumor volumes do well, regardless of the phenotype. But patients with large tumor volumes behave different, depending on the phenotype. Patients with the GCB phenotype do better, than the patients with large tumor volumes and the ABC phenotype. So that's a nice example of how we can try to offer added value to liquid biopsies and therefore to support the use of imaging in the assessment of cancer patients. Another example. Here, Lisa Baudet and colleagues, this is a multi-center trial where Berka participated too and other centers. They offer what they call the peptide therapy prediction quotient that combines the transcript expression in blood and the tumor grades. And notice how well this quotient works in terms of accuracy as compared to the grading or the clinical status or the FDG findings or the accuracy in terms of sensitivity, specificity, and positive and negative predictive values. And that worked in the different centers that participated in the study. Well, along the same line, Grohet in France, they proposed to combine a genomic grade index with FDG PET-CT to predict response to neoadjuvant chemotherapy in triple-negative breast cancer. Here, the dot lines is the complete pathologic response. These patients with no pathologic response. What is important from this study is that the best prediction of complete pathologic response was achieved when baseline SUV max was combined with the genomic grade index. providing another example of what do we need to do to offer added value to the use of liquid biopsies. Now, let me switch for the moment to cardiovascular medicine. Here we still have a lot to do. We notice this is recent data on the proportion of all deaths due to major causes in Europe. This is for men and this is for women. Notice that still the major causes of death is cardiovascular. That includes a stroke, but still is cardiovascular, as compared to the proportion of deaths that come from cancer. So still a lot to do in medicine here. Here I believe that in the next future, we will still see more and more research trying to offer a clinical means to identify the plaques that may result in an acute event. We have in the past seen with frustration that it is true that the target is there, our ligand goes there, but then the signal is too fine to permit in vivo assessment. This is because the concentration of the target is small and other factors. But I believe that we still have a chance there. And as an example, this comes from Hanover, will be published soon in EGNMMI. It is, in this case, they target the CXCR4 receptor with gallium pentixafor. And notice the high contrast of the images. And notice how well the plaque is seen, both in the ungated and on the gated scan. So I believe that there is still hope there, and that in the near future we may see results. Just keep in mind that in cardiovascular medicine, genomics is also arriving. We now know that by employing a 50-variant genetic risk score, if you have a high risk score, you are at high risk of events. Same happens with family history, that was known since long. If you have family history, you are at higher risk than if you don't have family history. But combining both, if you have family history and you have a high gradient score, you are at higher risk. So risk is still important in cardiovascular medicine. And here I would like to bring a thought. To assess risk at the level of the individuals, at the level of the individual patient, this type of individual calculation sheets will become more and more popular. And I believe that this model can be also extrapolated to oncology. Notice that in these sheets, one can enter the patient characteristics, data from the history record of the patient, and laboratory results, and at the end, this Excel file gives you a number that indicates the risk for this individual patient. In this particular case, this is to use atorvastatin. The number is 25. It means that you need to treat 25 patients, like this one, 5 years to prevent one event. Well, that's nice, and it works well. But notice that for our imaging studies to be integrated here, we need to keep it simple. I mean, a number or a result of a test in terms of positive, negative, myocardial perfusion scan positive or negative, or with a score to indicate extent of the disease, that's okay, that can be easily integrated. But complicated multi-parametric imaging that requires a one-page report, that's impossible to integrate here and in general in the history records of the patients. So we should try to keep it simple. And this is why I believe that lymphoscintigraphy will stay in the near future, because it keeps it simple. It is intuitive, easy to understand by the surgeon, with appropriate display of the SPED-CT images, with volume renderings. We largely facilitate the navigation to the surgeon for the proper planning of the surgery. And then in the operating room, by employing radiolabeling together with some optical system, we will largely facilitate the appropriate removal of the nodule. So I believe that lymphoscintigraphy will stay because it is a simple, straightforward, and intuitive method. So as my final remarks, if we try to shape our future and we focus on unmet clinical needs, we forget about situations or scenarios in medicine that are run well with current methods. If we develop appropriate partnerships nowadays with genomics, we need to not to fight liquid biopsies, but we need to try to demonstrate added value to combine with genomics and liquid biopsies. If we then try to gather evidence soon, we have not been doing well here. By history, we stick to single-center, retrospective, Me Too studies. We should move away from this, and we should try to gather very soon as possible, multi-center, prospective, if possible, randomized studies with a good reference standard. Try to gather evidence soon, and try to keep it simple. If we are able to do so, I believe that our future ahead will be bright. Thank you very much.
Thank you very much, Professor Carrió. And we want to present Ignacy with this gift from the World Fed board. Next, we have Professor Roslyn Francis with the lecture Multicenter of Clinical Trials and Trials Network, Enhancing the Future of Nuclear Medicine.
Thank you very much. And can I say what a fantastic 2 talks so far, where we've learned very much about the future. I think our challenges for the future. And I guess I'll be speaking a little bit more about the immediate future and how we can ensure we're very much involved in that in nuclear medicine. So I'll be talking about multi-center clinical trials and trials networks and enhancing the future of nuclear medicine. So I'll be talking about imaging and what is the role of imaging, clinical trial designs and outcomes, multi-center clinical trials and trials networks, rewards and challenges, disruptive technology and how we embrace change in our specialty, and enhancing our future so we can explore the potential of nuclear medicine. So what is the role of imaging in patient care? Why do we image? We image to diagnose disease, and this is usually performed early in a disease process in staging scans or assessment of recurrence, and you want to usually identify a site of disease, and you need really quite high sensitivity for these kind of methods. But we also image to characterise disease. This may be for later in disease process or advanced disease, or it may be to identify targets or assess response, to direct treatment options, and as we've heard so clearly, this is very much the concept of personalised medicine. I've always quite liked this definition of molecular imaging, which I found on Wikipedia a few years ago, and molecular imaging enables the visualisation of the cellular function and the follow-up of molecular processes in living organisms without perturbing them. And this is really key to what we do in our imaging and the value that we can add. And I've also shown on several occasions this particular slide because to me it really characterises what we are actually doing. And this is a slide from Lancet Neurology in 2010 looking at glioma cells and looking at the multiple molecular pathways within the cell. And we already image several of these pathways. As we can see, we image with FDG, and that is a molecular pathway which is modified by glucose transporter activity and hexokinase activity. We also image amino acid uptake, which is upregulated in malignancy through amino acid transporters. And we image for DNA proliferation through FLT, upregulated through thymosin kinase activity. But there are multiple other cellular processes which can be imaged, and we have the potential to image and to look at biology of a cell. There are molecular processes, there are cell surface markers, and the cell sits within a microenvironment, which is incredibly important for the host and tumour interaction. It is also important to remember that imaging is beyond just seeing sites of disease. The imaging that we perform is as a biomarker. This is results from our particular site where we're interested in mesothelioma. Mesothelioma is a disease with a terrible prognosis, highly resistant to treatment, and we have certainly been looking at some of those resistance factors in patients. And in this case, if I can show you, this is hypoxia imaging of mesothelioma. And here we see that, that in the mesothelioma there is hypoxia present in cells, particularly in bulky areas, but it's in a heterogeneous distribution. With the FDG imaging, this was a patient who had the FDG at the same time as the F-meso imaging. Again, you see heterogeneity of activity within the tumour bulky areas. This patient was receiving radiotherapy to a painful chest wall metastasis as the tumour was coming through the chest wall. They did show post-treatment a reduction in the metabolic activity, but interestingly, there were areas that remained very metabolically active, which matched quite well with the areas of hypoxia. So we can continually learn about what is happening in vivo within tumours and the processes that are occurring by imaging patients. So I wanted to talk a little bit about clinical trials in imaging and the design and the outcomes that we're looking for. So what kind of clinical trials involve imaging? There are trials designed to assess a new imaging agent and trials which utilise molecular imaging in patient selection to assess biological effect or for therapy monitoring. And they're the intelligent clinical trial designs that we are likely to become more and more involved in. So in terms of evaluating new imaging agents, novel molecular imaging agents offer the potential for highly specific imaging for improved diagnosis, prognostic stratification and therapy assessment. But the development of these agents require validation in a clinical trial setting. The agents usually have no pharmacological effect, so they won't perturb the host. So traditional drug therapeutic trial design may not be completely relevant, but we do need to have endpoints which are meaningful, and these do include efficacy of some kind, safety, outcomes, and usually these days we are being asked to produce evidence on economic impact. So just to really simplify the process, a great idea comes about and an agent is developed and tested and thoroughly examined, and then usually brought to the preclinical environment where we look at localization, biodistribution and dosimetry and decide whether to go forward with an imaging agent. Then the agent is looked at in a clinical trial setting initially for safety, localization, biodistribution, dosimetry, dose-finding studies. We then move on to the equivalent of a phase 2 clinical trials where we start to look at clinical indications, acquisition protocols and analysis techniques. These are often single-centre studies, prospective, or occasionally in our particular field, often retrospective, because we know that these agents don't cause any pharmacological effects, so we tend to be early adopters and use them in settings and then retrospectively review our results, and Ignacio talked about that as well. But unfortunately, this often means that at many sites there are different protocols, different analysis techniques, different indications, and we kind of cause some confusion in our field, particularly relating to the clinicians on how to adopt our imaging agents. An example of this is we have been interested recently in setting up a multi-centre clinical trial of FET PET scanning in high-grade glioma. And when I was looking at some of the work that had been done in this area, there is a meta-analysis published a few years ago looking at the performance of FET PET in differential diagnosis of primary brain tumours. And you can see that there are multiple single-centre trials that have been done. This is very typical of the evidence that is generally available in our field. The number of patients in these single-centre published studies usually are around 15, 20 to up to about 50 patients. But interestingly, even when it comes to image acquisition protocols, as you can see, every single site has a somewhat different imaging protocol. And I haven't even showed here the analysis that was performed because every site has some different form of determining, in fact, what was tumour from non-tumour. And this makes the evidence not quite so clear when often a lot of these agents are actually extremely promising. So we need to progress beyond the single-centre clinical trials of new imaging agents. We need to progress to solid validation, clinical impact trials, and this will really help the process towards regulatory approval and funding. So just to go back to the different kind of trials that we can do. So initially I talked about if we develop a new imaging agent, how we can actually move that forward. But actually more and more I think that molecular imaging is going to be critically important in clinical trial design. So we can already use our molecular imaging techniques to determine patient selection, assess biological effect, and assess response to therapeutics. And molecular imaging endpoints contribute to intelligent clinical trial design, and they actually contribute to more rapid clinical trial development, which is increasingly important. So very simple examples are for patient selection. You might use gallium-68 octreotide PET to confirm somatostatin receptor expression prior to entry in a clinical trial. You express a target, you enter the trial or not. Biological effect is increasingly important. Again, I agree very much that cardiovascular risk is something extremely important, and there are techniques such as sodium fluoride PET looking at early calcium, early microcalcification, which might be a potentially modifiable risk. And so we can actually then use this as a biomarker of interventional studies. So we need to get more involved in these particular clinical trials. And of course, we all know how amazingly important FDG PET can be in response evaluation, but there are certainly other imaging agents that also have enormous potential. But it's not only about assessing response, it's actually then how does that affect the treatment of patients. And these days, FDG PET is being used increasingly on decisions for escalation or de-escalation of therapy. So I wanted to talk about multi-centre clinical trials and trials networks, some of the challenges and some of the rewards. So multi-centre clinical trials in imaging are increasingly important in establishing clinical impact of imaging on patient management decisions and clinical care. And as I said, funding and regulatory bodies require data on safety, test performance, how an imaging test may influence patient management, clinical outcomes, and increasingly very much focused on economic analysis. So the advantages of multi-centre clinical trials is you can recruit larger patient numbers than a single site study, which is particularly important in rare or uncommon conditions, and you can often recruit quite quickly. Larger patient numbers results in an increased likelihood of significant findings or outcomes which are clinically relevant. Patients have access to an imaging or therapy agent on a clinical trial, which might be otherwise unfunded or inaccessible. Sites develop experience with new agents or therapies within a well-structured clinical trial protocol, and the selection or site bias of single-centre studies is reduced by testing of agents in multiple centres, which provides a bit more of a real-life setting. But there are challenges in these particular trials, and conducting multi-centre clinical trials in imaging has its own unique challenges. As we've talked about, there are individual site variations in PET cameras and imaging protocols, which really must be harmonised for successful multi-centre clinical trials. There are significant complexities in data analysis and centralised data review. Recruitment of patients depends on collaboration with your clinical teams. You might have a great test or a great idea, but if you can't bring in the patients, then you won't be able to move forward with looking at the value of that test. And clinical trials of imaging are expensive, and there are very limited funding opportunities. Certainly traditionally, there has been limited opportunities for us to be funded for these kind of trials, especially in comparison to drug intervention studies. So this is where trials networks can potentially help. So trials networks can support multi-centre clinical trials by harmonising imaging protocols, assisting in the process of centralised data review, forming linkages with other trials groups to assist in clinical relevance and patient recruitment, and creating leverage to enhance funding opportunities. The Australasian Radiopharmaceutical Trials Network, or ARTNet, is a joint venture of our two professional societies. We launched ARTNet in 2014 with a mission statement of aiming to promote and facilitate innovative, collaborative clinical research utilising radiopharmaceuticals for imaging or therapy. I encourage you to visit the website, and I do declare I am the current scientific chair of ARTNet, so I will be speaking more about it. So at this stage, I'm going to move on to disruptive technology, and with a particular focus on PSMA PET. We are all aware of PSMA PET, and we have all seen these exquisite images which have very much changed our practice and what has happened in the last few years, with this ability to detect disease that we really didn't have an imaging test previously available to do. And this paper came out a few years ago now, and I think it very much opened our eyes to the potential of PSMA PET, and in particular, the fact that really at very low PSA levels, we can actually start detecting disease sites, which we knew the disease was there because the PSA level was raised, but we didn't have an imaging technique to find it. And these were really astounding results which caused the community to stand up and really take this imaging test seriously. However, this is a retrospective review of 319 patients, no inclusion criteria. So again, this is initial evidence, and it is certainly extremely promising, but there is more work that can be done. So I say that PSMA PET is a disruptive technology because it really was just a major game changer compared to what was previously available. It had improved performance, high quality images, and because of that, it was rapidly clinically adopted. But the evidence at the time of that rapid clinical adoption was actually not strong. It was single centre, frequently retrospective, and usually relatively small patient numbers given the numbers of such a common disease such as prostate cancer. And it really has left several unanswered questions. What is the impact of this imaging test on patient care decisions, and how will this test improve patient care? So as part of ARTNet, one of the early trials that we undertook was a multi-centre prospective clinical trial looking at the impact of gallium-68 PSMA PET-CT on management intent in prostate cancer. And this was led by Paul Roach. So this was a study which recruited very quickly over a period of 10 months, was able to recruit 431 patients in 4 hospital sites across Australia. The patients that were recruited, 25% of them were for primary staging of prostate cancer and 75% in the biochemical relapse setting. And the study was relatively simple. The referring clinicians were required to fill out a questionnaire of management intent at the time of requesting their PSMA PET scan. If they did not fill out the questionnaire, they did not get the PSMA PET scan. The PSMA PET scan was then performed, and then a questionnaire was then sent to the referring clinician as well after the PSMA PET scan to gain an understanding of how the test had influenced patient management. So in terms of the result, the question of whether management was changed as a result of the PSMA PET scan, the answer was yes in 51% of patients. So half of the time, the management that was intended for that patient was changed as a result of the test. This was particularly high in biochemical recurrence, where 62% of the patients, there was a management change directly as a result of PSMA PET imaging, and in primary staging, that was less at around 21%. So that was great evidence prospectively acquired in a questionnaire-based study, but in a multi-centre environment, real-life setting, and gave us an idea of how this test is impacting patient management. We've also been very interested in Australia at looking at PSMA PET in primary staging of prostate cancer, because primary staging has potentially high clinical impact in patient outcomes due to the identification of extraprostatic disease, because we know many of these patients do subsequently relapse. And again, with rapid clinical adoption in this country already underway, there were challenges with developing a trial design acceptable to patients and referrers. So Michael Hoffman, I think you would have hopefully heard talks from him at this meeting, and he has been the principal investigator in a trial called Pro-PSMA. And this is a trial which has been funded by Prostate Cancer Foundation Australia and Movember, looking at the role of PSMA PET-CT imaging in the management of prostate cancer. This is a multi-centre prospective clinical trial. Initially there were 8 sites proposed across Australia with 2 added, so there are now 10 sites across Australia participating in this study. This study has hypotheses that PSMA PET-CT has improved diagnostic performance compared to conventional imaging and staging of intermediate and high-risk primary prostate cancer, that PSMA PET-CT should be used as a first-line diagnostic test, that the improved diagnostic performance of PSMA PET will result in significant management impact, and that there are economic benefits if PSMA PET is incorporated into the management of these patients. This design is interesting. It is a prospective 2-arm randomised trial in patients with intermediate or high-risk prostate cancer being considered for curative intent. 200 patients planned across 10 sites. And I have to say this trial is recruiting unbelievably well. It is the only trial that I've ever seen that has actually met the recruitment timelines that were projected at the start of the study, and all 10 sites are activated across Australia. Patients are randomised to either PSMA PET imaging or conventional imaging with bone scan and CT, but they have the opportunity to cross over to the other imaging technique if they have negative first-line imaging or oligometastatic disease. So most patients will access PSMA PET through this clinical trial. So this clinical trial, ArtNet was involved in initially for support in terms of the concept and support in getting the grant funding and liaising with the other trials group, and also in protocol development. But ArtNet has also been involved in the quality or harmonisation aspects of the trial, particularly with camera calibration and site initiation and development of radiochemistry protocols and QC. And I just wanted to spend a few minutes talking about one of the unexpected findings of this study, which actually comes to how you must make sure that when you do conduct multi-centre clinical trials of imaging agents, that you do ensure there is harmonisation. So as part of this study, ArtNet undertook the site initiation aspects of the trial, and part of this was to calibrate all the cameras participating across Australia for gallium-68. So a NEMA phantom was sent to participating sites with instructions provided on the method of filling the phantom and acquiring the images. And results were uploaded for analysis by a core lab. An unexpected finding occurred, and that was that there was a discrepancy between the expected and measured SUV for gallium-68. And this didn't occur in 1 or 2 cameras, this occurred in 10 out of 14 cameras assessed. There was an underestimate of SUV, which was consistent, and on average by about 15%. The discrepancy was at multiple sites and on different manufacturers' cameras. There was an investigation obviously undertaken of why this might occur, but there are some challenges in this because gallium-68 has a very short half-life. Australia is a big country, and there was no traceable reference source. Eventually, after much work headed by Dale Bailey, it was found that the cause was actually an incorrect factory-shipped dose calibrator setting from a single manufacturer. And this has actually been published this year in the Journal of Nuclear Medicine, and I would encourage you to read this study because it is extremely interesting, and for us was a very unexpected finding. And it highlighted the importance of a system of camera calibration prior to commencing a multi-centre clinical trial of PET imaging, in particular for trials in which quantitative measurements are used. And I would say in particular for trials that maybe you're not doing, there was no other reason, I guess, for us to have looked at gallium-68 across the country. And I have to say this is particularly important because it impacted not only the clinical trial, but actually clinical practice, because we realised that the readings on our dose calibrators were in fact incorrect. So ArtNet is involved currently in several clinical trials. As I talked about, there was a management impact study of gallium-68 PSMA PET, which is completed and published. The Pro-PSMA clinical trial in primary staging of prostate cancer with Michael Hoffman as the PI. All sites are activated, and as I say, recruitment is meeting targets and is actually occurring at a really high rate. There is also a therapy clinical trial with Michael Hoffman as the lead investigator. Now, this is a randomised prospective clinical trial of lutetium PSMA versus conventional chemotherapy in prostate cancer. So this is the multi-centre clinical trial approach that we have been looking for. And this trial has opened. It is an ANZUP, which is our Australian Uro-Oncology Trials Group trial, and it is an early patient recruitment phase. And recently, we were very pleased to receive funding of a trial of FET-PET in high-grade glioma led by Professor Scott. This has recently been received through our government funding system, and it is a collaborative project through ARTNet, our Radiation Oncology Trials Group, and our Clinical Oncology Trials Group. And again, in an area very much needed to gather more information, the role of FET-PET imaging, looking at prognosis, radiotherapy planning, and the assessment of pseudoprogression. And I can say that there are many other trials really close on the horizon. So to finish off, I wanted to talk about, just briefly, enhancing our future. And we are living in an age of rapidly evolving technology, as we've heard. Imaging agents, imaging technology, and imaging applications are rapidly expanding. Translational research will increase the speed of development of therapies by understanding and visualising the mechanism of action without perturbing the host, and this will lead to intelligent drug development. And incorporating molecular imaging endpoints in multi-centre clinical trials is challenging, but it has the potential to add enormous value. Again, I also have a similar theme of the biomarkers, and there is an increasing recognition of interplay between systemic biomarkers and imaging features in tumours. And so in designing clinical trials, it's important to collect imaging data which is robust and will answer clinical questions, but it is important to enrich imaging studies by incorporating biomarkers, and I think we've clearly heard that theme this morning. And I just have to say, this can be achieved in a multi-centre clinical trial setting, and it will lead to an increased understanding of complex diseases. So in terms of future predictions and goals, there will be an increasing recognition of the value of molecular imaging in translational research. Multi-centre clinical trials will increasingly incorporate molecular imaging endpoints. Clinical design, conduct, and comparability across sites is critically important for validity of data. And trials groups such as ARTNet can help facilitate this process. Now, I've obviously given a very regional perspective on this, but I know a lot of work has gone on in other areas, such as by SNM, MI-CTN, EANM, EARL, and ECOG ACTRIN studies. And this is an area, I think, for which we can become involved in for our future. So my final words are that with a culture of collaboration, the future of nuclear medicine is strong. We have an opportunity to explore the potential of our specialty, to understand the role of imaging in clinical management decisions and how to improve patient outcomes, to link with other specialties to identify and answer important clinical questions, to develop standardised protocols or techniques which can be shared, and that is very important, to utilise imaging to enhance scientific breakthroughs and drug discovery with an ultimate aim of improving patient care. So I'd like to acknowledge the staff that I work with in Western Australia, who are a fantastic imaging unit, the University of Western Australia, and all my clinical collaborators for my work, the trials networks which we've become involved in and have a great relationship with, and most of all to the nuclear medicine departments across Australia for their generosity and willingness to collaborate, because I think we're building something really important for the future. Thank you.
Thank you very much, Professor Francis. And now we want to present you with this gift from the World Federation Board. Thank you very much for attending this session. I just want to remind you that the Congress highlights and closing plenary will be promptly at 17 hours, 5 p.m.